My name is Peter Geller, and I'm an associate professor of surgery at Columbia University and an attending surgeon at Columbia Medical Center in New York City. I have a particular interest in abdominal wall hernias and have been focusing my practice on that specialty for a number of years. Abdominal wall hernias have been repaired by doctors for many centuries. Here's an illustration from a medieval document showing an early version of a hernia repair. We've improved our techniques somewhat since that time. I think our anesthesia is a little bit better than it was back in the 1400s. I think also we have learned something about human anatomy in that time that has permitted us to perform more successful hernia repairs. The anatomy of the abdominal wall is complicated but understandable. It consists of a number of layers. Those layers consist of muscle and fascia. Fascia is the white gristly material that you see in this illustration. Muscle appears joined to the fascia. And what we have learned, in addition to the fact that muscle and fascia are layered on the abdominal wall, is that there are areas of the abdominal wall where fascia is not supported by muscle, and in those areas people tend to get hernias. The areas that I'm referring to are along the abdominal midline in the linea alba, the white line that runs from the top of the rib margin down to the pubic bone. And you see in this illustration that people may develop hernias anywhere along that midline, and also in other areas where the fascia is either absent or has been damaged by prior surgery. Areas such as the inguinal canal or in an old appendectomy scar, fascia may be damaged or absent, and the muscle may be damaged or absent, and people will get hernias there. A hernia consists usually of intestine protruding through a defect in the abdominal wall. That situation is illustrated toward the bottom of this slide. The intestinal protrusion may be chronic, or it may result in an acute condition called intestinal strangulation if the blood supply to the intestine is cut off by the rigid rim of the hernia. Perhaps the most common hernia that we see are hernias in the inguinal canal. This drawing illustrates the anatomy of the inguinal canal seen from the front, with a structure called the spermatochord pulled laterally. You see in the illustration that there is an unprotected area that we call the deep ring, or the myopectineal orifice more generally, where there is an absence of fascia and muscle. More precisely, there is a thin layer of fascia there that may become attenuated due to chronic pressure or other changes in the health of the patient. We know that factors that predispose to hernia formation include prior surgery in the area, as mentioned earlier, obesity, increased intra-abdominal pressure of a chronic nature, such as fluid in the abdominal cavity called ascites, and also simply the process of aging, where the collagen of the abdominal wall, and in fact of the entire body, becomes weaker due to changes in the composition of the collagen. An inguinal hernia will frequently present as a lump or a mass in the inguinal canal, and the lump is frequently a herniated loop of intestine. This may lead to strangulation, as mentioned earlier, or discomfort, or simply an enlarging inguinal bulge. Another frequent location of abdominal wall hernias is the umbilicus. The umbilicus, or the belly button, is an area of fascia unprotected by muscle. intestine may protrude through this weakness as it does in the inguinal canal. We often see small children with umbilical hernias. This may be a congenital defect, that is, a defect that people are born with, as well as an acquired defect due to the conditions that I spoke of earlier, such as aging with degradation of collagen or increased intra-abdominal pressure. Not every hernia needs to be surgically managed. Dating back to the Middle Ages, people wore devices that today we call trusses to support the abdominal wall externally and avoid the need for surgery. This was especially desirable during the period of time when surgery generally resulted in mortality. Trusses continue to be manufactured. More modern versions are fairly lightweight, and patients who are not good surgical candidates or who are fearful of surgery will sometimes employ a truss rather than undergo surgery. Again, the purpose of the truss is to apply external pressure to the area of abdominal wall weakness. Surgery on the inguinal canal in earlier times was accomplished using stitches. We would expose the weak area and sew the healthy tissue that bordered the area together and closing the hernia defect thereby. This technique, illustrated here, is commonly known as the Bassini repair, after an Italian surgeon who popularized it. This is a good repair, but it is a repair performed under tension. That is, the sutures are pulling tissue together under a certain amount of tension, and experience has taught us that this may lead to chronic pain in the region. Since the 1950s, the development of polymer chemistry has permitted us to develop devices that allow a tension-free hernia repair to be formed. Illustrated in this picture is a number of polypropylene mesh devices, both a patch and a plug, seen in two views, that we use to reinforce an inguinal hernia defect and perform a tension-free repair. This is an illustration of the placement of a mesh patch over the undefended space in the inguinal region, and this is the most common form of open inguinal hernia repair performed today. Repair of other hernias that I have mentioned in this talk, including umbilical and incisional hernias, frequently employ similar techniques, that is, the use of prosthetic material to reinforce the hernia defect. The discussion of the repair of all kinds of hernias would, of course, take a considerable length of time. I would be happy to discuss any of these matters with anyone who would be interested to contact my office. Thank you very much for listening.